Welcome to the Fogsi Presidential Gyan Pravah podcast number 315. I am Dr. Sarita Shamson, the chairperson of the Fogsi Gynecological Oncology Committee and your host for today. In today's episode, we have is very special. We have with us Dr. M.R. Rajagopal, widely recognized as the father of palliative care in India. As the founder of Pallium India, he has devoted decades to making quality pain relief and compassionate care accessible to millions, and through his work has reshaped how our country thinks about suffering, dignity, and death. Over the next hour, we will talk about his personal journey into medicine, what inspired him to step away from conventional treatment and embrace palliative care, the challenges and triumphs of building a nationwide palliative care movement, and his hopes for the future, not only for patients, but for how society, community, and healthcare can evolve to ensure that no one suffers in silence. Dr. Rajgopal, thank you so much for joining us.
Namaste. Good evening, everybody.
Good evening,
Hello.
sir. Okay.
Madam Dr. Sunita Tandulwadkar is the Foxy president for 2025, and this podcast series has in fact been initiated by her. And she started with this year's theme as Ek Rashtra Ek Mission, Swasth Nari Samruddha Vatan, Har Ghar Foxian. This resonates deeply with our mission to empower women and enrich lives. She has led so many impactful initiatives: Know Your Numbers, Sampurna Swasth Janma Abhiyan, Aprajita Sampurna, Do Teeke Zindagi Ke, flagship The Eagle Project, Arogya Yog Yatra, Gyan Pravah, Foxy Anuban Project Mukta, along with many publications, the Arogya Sakhi app, and we are weaving a strong and inclusive fabric that connects every Foxian to the heart of the association. These efforts ensure that each member feels valued, involved, and an integral part of our shared mission. Some initiatives for women's cancer have been this for cervical cancer has been the Do TK Zindagi Ke, that is actually educating the Foxy IMA. It's a Foxy IMA project to train 50,000 IMA doctors on HPV vaccination, the Nirmal Banaras Abhiyan for HPV testing, the Wave 2 educational program for Foxians on evolving science of HPV, and newer techniques to handle the myths, and also the Swasthanari Abhiyan Yatra. And she's always, and there have been so many projects coming up all throughout the year. She's always been ready, encouraging, and supporting in all our projects. Thank you so much, madam.
Thank you, Sarita. Thank you so much for remembering all the projects. This is because you are involved in many projects, Sarita. You are one of the most sincere, dependable, and very methodical in your work, Sarita. I really appreciate, and I think you are a big asset to our organization. I'm not saying it on for a face value. I'm saying it from deep from my heart. I have observed you. I never worked with you before, but as a president and as a committee chairperson, what I saw was dependability, passion, and everything what you want to or we have given you, you have worked very hard. Now, today, you have taken the your podcast also are fantastic, Sarita. And I'm so glad that you have explored everything around oncology in your all the podcast series and every day going successively for last 315 is thanks to you and all the committee chairperson who has taken this project so seriously. It's beautiful. It's na bhuto na bhavishyati. Even if now I'm taking over as a ISAR president, background team till that time, please call up sir. Probably his network is down and we will continue so. Even if I'm taking over as a president, I know in ISAR this is impossible. I can't do this job. That this job we could do only because you 30 cabinet ministers of Foxy. That is the only thing. And today, what you wish to discuss with him?
Yeah, it's about all the work that he has been, I mean, about how the evolution of palliative care in India, madam.
Okay. So according to you, palliative treatment plays a very important role in every oncology. So it is
Yes,
so
yes, ma'am.
important. Welcome back, Dr. Rajagopal, sir. And it will be one of the most important thing to learn and how passionately someone can work for a palliative treatment. So
Yes.
it is wonderful to have you, sir, with us. And thank you, Sarita, for having Dr. Raj Gopal with us today. And I'm sure it will be a very important podcast for everyone. And thank you, sir. To run this podcast every day, 8 p.m., is a mammoth job. And it was possible only because of my dedicated committee chairperson. I joined just to show the respect to the faculty for giving their valuable time. And I'll be joining the viewers link to listen to both of you. Thank you.
Thank you,
Thank you so
Dr.
much, madam.
Thank you.
Thank you for all the encouraging words.
Thank you.
So, Dr. Rajgopal, we will have some brief interview with you. So, if you could tell us about your early life and how you actually first decided to study medicine, and what led you eventually to become a pioneer in palliative care rather than conventional anesthesiology.
Thank you, Dr. Sarita. My journey into medicine was not my choice. Uh, I had got good marks, and I got the admission. My father said, "Go," and I went. It was as simple as that. I did not know my own mind at the age of 17. Uh, but thereafter, when I was doing first year of medical education, I had a neighbor, a distant cousin, fairly young man, who had cancer of the sweat glands, and his whole scalp was studded with small tumors. And all through night, I could hear his screams. At one time, he became all pain and only all screams. But even before that, he used to say he felt like somebody drilling into his skull. So the family went to the oncologist and they said, of course, if you have cancer, you would have pain. What else do you expect? I learned then that pain can be beyond one's imagination. We are dismissive about somebody else's pain, but somebody is saying that one man with osteosarcoma said it felt like an iron rod being pushed into his bone and twisted periodically. One man with cancer of the tongue said he felt like somebody putting a nail into his ear and banging. Why am I saying all that? Pain can be beyond one's imagination. I saw that early. And eventually, when I became an anesthetist, I saw that nerve blocks could relieve the pain. And I started doing nerve blocks. And that was my entry into pain management.
Right. So, what was there a movement or experience in your medical career that made you realize how urgent the need was for compassionate pain relief and palliative care in India as a whole, as a country?
So initially, my concern, I must confess, was only the patients that I saw.
Hmm.
And I was concentrating on nerves and
Hmm.
blocks.
Hmm.
A 42-year-old college professor gave up his life to teach me a lesson. I did a successful neurolytic block.
Right.
The next day, his pain was all but gone.
Mm-hmm.
He asked, when should I come again? I said, you don't have to come back
Hmm.
unless you get pain, but this pain relief may last for 6 to 9 months.
Hmm.
He killed himself that night because when I told him not to come back, then he knew that his cancer was incurable. Till then, he was
Okay.
hoping for a cure. That is something that his cousin told me. Now,
Okay.
with all good intentions,
Hmm.
I was an instrument in the man taking his life. And perhaps that was my introduction to palliative care. Till then, I was doing only pain management. And when I recognized that this business of palliative care looks beyond the pain, physical pain, to other symptoms, to psychological and social suffering, just as women with advanced cancer of the cervix would go through in our country, with at least 27% of them being abandoned by their husbands. And don't we have a responsibility towards them? Are we looking only at the tumors and the uterus?
Hmm.
Doesn't the person matter? So palliative care, well, not the official definition, is mitigation of serious health-related suffering, whether it be physical, social, psychological, or spiritual, and improving the quality of life of the patient and the family, because often the family suffers along with the person.
Hmm. Yes. So, what made you actually form this society of pain and palliative care society? And can you tell us about, when you started, what was the vision and what challenges you faced actually in starting community-based palliative care?
Initially, I must admit that when I started doing nerve blocks, a couple of colleagues will come and watch just to see what I was doing. And then these people would be telling me their stories, and they listened with me. And Dr. Suresh Kumar, who is now heading the Institute of Palliative Medicine at Calicut in Kerala, was a postgraduate student in anesthesiology, and he was there all the time whenever he could find the time to stay with these patients and help look after them. We found that the problems were numerous. I would prescribe a medicine 3 times a day after food. And a person said, no, just once a day, doctor. I had said after food, he would get only one meal a day. And we were writing prescriptions. They would not have the money to buy the medicines.
Hmm.
So in our conversations, this suggestion came up. Let us form a charitable society to pay for the person's needs. I
Right.
remember that Suresh said, let us aim higher than that. Let us
Hmm.
move out of this modest vision of treating a few people's pain. And then we started this Pain and Palliative Care Society for Northern Kerala, for 7 districts of Northern Kerala.
Right.
And the movement grew.
Hmm. And what motivated you to create Pallium India? And what gaps did you see in palliative care across the country? And what was the core mission for this trust?
Dr. Sarida, in the beginning, as I said, our vision was limited.
Hmm.
And we started something for just the northern districts of Kerala.
Hmm.
And it was so obvious. We needed pain relief. We needed morphine for pain, relieving agonizing pain in people with cancer and some other diseases. It was not accessible. So we had to work in Delhi with the Department of Revenue, with the Department of Health. And then we found that this was not only my place or Kerala, the whole country was in pain because of lack of pain relief measures. So we were forced to work with the government departments in Delhi also, And then it was obvious that the whole country had the problem. And we, in the first 9 years, had established a network of palliative care centers in northern Kerala. We found that the society was warm and welcoming. They were very enthusiastic. So we decided that we cannot confine ourselves to a small region. This was a problem for the whole country. And in 2003, we set up Pallium India with a national agenda, national outreach to relieve serious health-related suffering across India. Now, Pallium India has a footprint in every state in India and in 6 union territories.
Right.
The footprint doesn't mean all that much necessarily everywhere, but we are working in all these places. It's a long road ahead.
Right. So, who are all the people who work in Pallium India in each of these centers, sir?
So, Trivandrum is the only place we directly run a pain relief facility. We have regional facilitators. I mean, each regional facilitator works for 3 or 4 states. We have one in Delhi also. So these regional facilitators work with the state governments, with the National Health Mission, and with individual hospitals and groups of hospitals, with individuals who are interested. And from our headquarters, we conduct educational programs in palliative care for the whole country. Well, to a large extent electronically, but also in-person courses. So we call our work as DEF, demonstration, education, and facilitation. Demonstrating palliative care delivery in our headquarters, as well as with our collaborators across the country. So elsewhere, if Dr. Sarita says, let us look at the palliative care needs in my department, our regional facilitators facilitator will be there with you next week.
Right.
And work with you to develop palliative care.
Okay. So you have doctors, you have anesthesiologists, and you have nurses in your team in each of these centers?
No, Doctor, in all these places, it is our staff would be just a facilitator.
Okay.
Collaborating with institutions.
Right. Okay.
So
Okay.
if Safdarjung says, let us establish a palliative care clinic, our facilitator will be there, but we will not be running the service. India is too huge a country, and anyway, if we started without roots locally, we don't think it is sustainable. But so many people are interested and we work with them. The facilitator only facilitates demonstration, education, and then works with local governments for policy and implementation.
Right. So you played a key role in policy advocacy, including easing access in essential pain relief medications by influencing the amendment of the Narcotic Drugs and Psychotropic Substances Act. So can you tell us about this journey, sir? Its challenges and resistance you faced, and what finally made the change possible?
When we talk about the history, is that America's war on drugs led to an international convention called the Single Convention. And one of its jobs was to control access to opioids, control, so that addiction doesn't happen. Now, that led to India's Narcotic Drugs and Psychotropic Substances Act in 1985. Now,
Right.
Before that, I qualified in the 1970s, early 70s. As a house surgeon, I could write a prescription for injection morphine, and the patient's family could get it from across the road from a medical store. That was possible. But the law made it impossible. So India, even as in 1985, when the law came into place, we used to consume about 600 kilograms of morphine. That's a small amount for such a huge country and such a huge population. Once the law came in the next 13 years, from plus 600 kilograms, it dropped to 18 kilograms. Because the law is called the most draconian law in all democratic world. So all its complications reduce the access. So when we wanted to give pain relief to people, we needed oral morphine. We found that it was next to impossible. So we had to advocate, and that brought us to India. And our affair with Department of Revenue, North Block, became a frequent place where we had to be there for meetings and things. And one Mr. David Joranson from a WHO Collaborating Center in Madison, Wisconsin, worked with us, helped us a lot. So, a lawyer in Delhi, Ms. Tripti Tandon, gave her services free for us from Lawyers Collective, and we could prepare a draft amendment sitting in the narcotics director's office room. It took us a long time. It took us 19 years of efforts for the Indian Parliament to change the law, make it rational. Even now, that doesn't mean that anybody can get morphine whenever they want to. There are controls, but only enough controls to prevent inappropriate or non-medical use. See, if you want to protect your home from burglary, when you go out in the morning, you lock the door. One key, one lock, one key. You keep the key. You don't put 5 different locks and hand keys to 5 different people, then you can't get back in. This is what happened to the NDPS Act. Multiple agencies were involved, and eventually nothing worked. So the amendment just reduced it to one lock and one set of keys, which stays with the drug controller of the state. The control is still there, but it is rational control.
Right. I think that will definitely, that helps patients definitely for the pain relief. I think that was so vital to have that. So, because today's figures show that only 4% of Indians have access to palliative care, even decades after the movement began. So, what do you think are the biggest barriers in improving access to palliative care in India?
Oh, I wish it was one barrier, then we could have jumped over it. So, one thing I told you, that from the time of the creation of the law, we have what is called, we call it opiophobia, fear of opioid substances. As I said, we used to use it. Doctors used to use it. And we know that somebody with myocardial infarction and agonizing pain needs it as a life-saving measure. But we do not have it. So the barriers are this fear. Some realistic fear is good. This is unrealistic fear. But the fact that India is a huge country, the law is changed, but the implementation has to be by the state. The state drug controller has to implement it. And our facilitation team has worked over these last so many years The law changed in 2014. It has been 11 years. They have to make sure that the drug control authority in the state understands the law and implements it. That's a long struggle in our huge country. But I'm glad things are gradually improving. Yes, I'm not proud of the fact that less than 4% of the people in India, even now, have access even to basic pain relief. But then I would also think that in a country with 1.4 billion population, from next to nothing, 4% is a huge change. And especially in the last 10 years, so many major policy changes have happened in addition to the legislation. So that I truly believe that we are on a steep part of the growth curve. And now things are going to get steadily better.
That's good, sir. So, what role do you feel, the community-based care and home-based palliative services should play in India's healthcare model, considering geographic, economic, and social diversity in the country? It is difficult to implement it across India, but how do you feel this can be done?
So, in response to that, I will ask all who are listening to think. You must have had a serious illness experience in your own family. Somebody getting some illness or other. Who does the most caregiving? Healthcare is provided by whom? Dr. Sarita sees the patient for a few minutes, say a week or a fortnight. The nurses during admission may spend more time with them, but the bulk of the healthcare is provided by the family and the immediate community around them. They are the ones who are doing most care. By empowering them, giving information to them, giving instruction to them, that itself makes a dramatic change. When they are discharged, we usually tell them, okay, look at this. This 3 times a day after food, this once a day before food. They don't understand. It is too much of information. But a few minutes spent at it, giving essential information to the family helps. And except in the cities where we are very sophisticated people living very nuclear families, in most of India, there are still joint families. There are people who help one another. And the community is existing in most parts, except urban areas. And they can be a strong force. They can be allies. So I know that there's so much of poverty that not many will have the spare time, but usually there'll be some people. I've seen this not only in Kerala. I have worked with an organization called Samraksha, which works with HIV/AIDS. I've seen how their social workers, who are mostly HIV survivors, go to the rural areas where they have rejected a patient with HIV, thrown him out of the village. They work with the village elders, and in a week, the village takes the person back. Very often we mistake education for synonym with intelligence. It is not.
Yes,
The
yes, true.
average villager is intelligent enough. Sometimes they have so much more experience than us in facing adversities.
Yes.
You lend them a hand and they do a lot. Having said that, it is not a simple process. But I'm not saying something outside of the textbooks. Public health world knows this. Alma Ata Declaration in 1978 said, make the community partners in healthcare. Reinforced 40 years later by Astana Declaration in 2018, went one step further, give some control over healthcare to the community. Because healthcare is not only dishing out medicines and operating on people. Health is physical, social, and mental well-being. And as the Astana Declaration points out, and we can imagine, irrigation, agriculture, industry, transport, so many things, they are all involved in making a person healthy. That's where the community comes in.
Yes, absolutely. I think, and India is one of the, I mean, in our country, it's good that there are families. I mean, there is support from the family, extended family, that actually provides a lot of help to them. And it's when most of the time they are the ones, as you said, they are the ones who are taking care of the patient, and it's because of them. And sometimes it is for months and years also that they are taking care, and that we see them, coming, recovering so well after months and years. That's thanks to the family who has been taking care.
Absolutely, absolutely.
Yes, sir. So you have often emphasized that relief from pain is a human right, it's not a privilege. So what does that belief mean for you personally, and how should it shape healthcare policy and practice in India?
Dr. Sarida, very often, especially over the last half century, we have medicine has grown as a science. Unfortunately, it's a lopsided growth. What is health? Official definition. It is physical, social, and mental well-being, and not only absence of disease or infirmity. Which hospital looks after physical, social, and mental well-being? So why do we focus on diseases? It's easier for us. If somebody is in depression and has a suicidal ideation, it takes time and effort to address that. Doing a surgical procedure takes less time.
True.
We do what is convenient for us. And if you do an hour of counseling for that person with suicidal ideation, how much can the hospital bill? And if it is a 1 hour procedure, how much that can they bill? These are all realities in a country where 65% of healthcare is in the private sector. So it's about recognizing health for what it is. And pain relief, as I said, pain can be beyond one's imagination. And we have the means. Mahatma Gandhi used to talk about passive violence. What he said was, there is enough food in the country, and that's being denied to all the poor people in the country. It is there, but denial is happening, and there is a passive violence. We grow poppy in Madhya Pradesh, Uttar Pradesh, and Rajasthan under license. Farmers grow poppy. Our factory produces opium, exports shiploads to the Western world so that they can have pain relief. This is inexpensive. We deny it to our own people. That's passive violence. And we have the responsibility. What's the healthcare duty, healthcare provider's duty of care? In India, is officially defined by the bioethics unit of ICMR. The healthcare provider's duty is to mitigate suffering. It is to cure sometimes. In gynecology, what percentage of patients would have curable illnesses? A significant number. But how many would have incurable illnesses? We don't even treat them. We send them to oncology and we don't know where they end up. The healthcare provider's duty is to cure sometimes, relieve often, and to comfort always. And the definition adds, there exists no exception for this rule. We have a duty to relieve suffering, and that we feel when somebody in our own family is in agonizing pain.
Mm.
When we have the means and we have the duty, not doing is dereliction of duty. When I come to you with pain, I believe it's your responsibility to relieve that
Mm.
pain, not only treat my disease.
Yes, sir. Absolutely. I think that is the most valuable thing actually, and that gives so much comfort to them. So, so how do you think this the pain and palliation as regards to how can we can we integrate into the obs and gynae practice?
So, uh, I hope things have changed. I remember from my days of being a house surgeon,
Mm.
the labor room was a place where a lot of violence happened. Women were snatched away from their family, put in a strange place, full of loud screams. I'm not talking
Mm.
about the big corporate hospitals, talking about the public hospitals where people like the lower middle class and poor people go. And there, imagine a young woman so totally afraid. Her mother would have stayed by her side, but no, she alone is taken away. Leave alone the husbands being allowed, which happens only in five-star hospitals.
Mm.
And there, very often doctors pronounce that no, labor pain is something to be borne. It's good for good for bonding of the child with the mother. My good God, what evidence do we have? We look at evidence-based medicine
Mm.
for so many things. I'm sure we don't have an iota of proof that a painful labor improves bonding between the mother and the child.
Mm.
And denying that pain relief is violence. That isolation from the family is violence.
Mm.
And leave
Yes.
alone the gynecological malignancies. Among all the people with cancers that we see, they have the worst suffering because of the foul smell
Mm.
and because women,
Mm.
Kerala is a lot better, I must say, still by and large, gender-based discrimination is a lot, and women go through sheer hell, and we don't see them. We refuse to
Yes.
see them. They're there. We don't see them. I really believe that men with cancer of the prostate would get so much better care than women with cervical cancer. So it's
Mm.
starting
Absolutely.
with our first meeting
Mm.
with a patient coming for antenatal checkup. Uh,
Mm.
if you recognize her anxiety,
Mm.
lay a hand on the hand and say, "We are going to look after you."
Mm.
What the amount of comfort you would be giving that
Mm.
person. And then treating the person and not just the pregnancy. Treating the person and not just a disease. That is crucial.
Mm. Absolutely, sir. Very true. So, as a clinician, activist, and educator, how do you balance compassion and professionalism, especially when dealing with end of life care, dignity, patients, and families' emotional burdens? That it's really hard at that time.
Professionalism. A few minutes back, I defined India's official definition of a healthcare provider.
Mm.
Health and health provider's duty that compassion is not an extra add-on. It appears to be. But a healthcare provider who doesn't have compassion will really is somebody that I would be scared of. At my age, I know that any day I may end up in a hospital. I would be scared of the human machines without feelings treating me. And a professional, healthcare professional, I strongly believe, is one that treats people. An engineer can look at machines that are well oiled and well understood. We are treating with human beings. I think professionalism cannot be devoid of compassion. Compassion and competence have to be certainly we need to be competent, but they are synergistic. And does that mean that in compassion I'll do something that is harmful, something that will violate the principles of medical ethical principles of autonomy, beneficence, non-maleficence, or distributive justice? I wouldn't. Because if I do, out of compassion, do something that is against the principles of medical ethics, that would be violating the whole medical professional ethics. I accept that. I'm sure compassion and competence have to be balanced. Otherwise, I would be, as I said, scared of being treated by a human machine.
True. Very true, sir. So looking back at your decades-long journey, is there anything you wish happened sooner or a path that you wish you had pursued differently to accelerate access to pain relief and palliative care?
Oh my God, almost everything. And one thing I wish I had brought in principles of management earlier. One, I wish I had not wasted so much of my life. I came into this field only around the age of 40. Still then I was being more or less mechanical.
Right.
But once we had started, we were professionals. We did not, we started a non-government organization. We did not know how to run it, how to scale it up. A lot of management principles come into it. And except in corporate hospitals, usually there are no people with management expertise. Of course, management expertise without the heart will be bad. But we were all heart and not enough brain. The balance between the heart and the brain are essential in healthcare. So I would have brought in a term that you employ, more professionalism into healthcare management, certainly. And I would have known better than to keep fighting the windmills. See, we were expecting a drastic, or we are even now expecting a drastic change. A change in the attitude of the medical profession towards me as a patient. That's not easy. Change is always resisted. And when you come across resistance, meaningless attempts at fighting against the resistance should be avoided. Management experts have taught me. So it's much more worthwhile to work with people who feel similarly rather than to keep fighting the antagonism. Eventually, the growth will happen because the facilitators, and when that happens, the antagonism produces. So
Mm.
there has been a lot of antagonism because of the resistance to change at all levels, among politicians, bureaucrats, professionals, the public, sometimes misunderstanding what we are trying to do. And the fact that we have become a death-denying society in recent years, is another problem. We refuse, 2 generations back, in joint families, everybody used to grow up seeing death, seeing people dying. Not anymore. And therefore, people find it harder as time goes by to accept incurability.
True, sir. So, what is your vision, sir, for the next 10 to 20 years for palliative care in India? And what changes do you think you can, in policy, medical education, public awareness, and community action, do you hope to see? And how can ordinary individuals contribute to making that no one suffers in silence a reality? What happened? He's logged out. 1 second. Let's call him. Huh? Oh, he's joined again. Welcome back, sir.
Are you audible now? Anybody?
Yes, sir. Yes, yes,
Oh, I'm
yes.
sorry about that interruption. I don't know what happened. So I was saying that if there was one thing I would have done earlier, it was advocacy. Going to the people. In Kerala, initially the resistance was stiff. Nobody would listen to us. But when the public accepted it, when newspapers wrote about it, when radio talks came up, then people accepted us. And that forced acceptance by the government and the healthcare system. So the community is powerful and we should reach them. The common person on the street is not necessarily educated, but that doesn't mean that he or she doesn't have intelligence.
Yes. So what is your vision, sir, for the next 10 to 20 years? And what changes in policy, medical education, public awareness, and community action do you hope to see? And how can ordinary individuals contribute to making no one suffers in silence a reality?
Coming to the last point about suffering in silence and in loneliness, abandonment, that's happening more and more. And that's happening more and more on the end of life, about which we have not discussed so far. End of life is an important period of one's life. In MBBS, till 2018, 19, it was not in the curriculum. It is now in the curriculum. And that's an important period of suffering. So, there was a Lancet Commission report published in, if I remember correctly, in 2022. It's called Commission Report on the Value of Death. They said, bring death back to life. Death was part of living at one time. As I said, used to see dying people in the families, and we knew how to support them. Now we have become a death-denying society. And the worst horror that happens today is the infliction of suffering in intensive care units. at the end of life. Solitary confinement, rigorous imprisonment till
Mm.
death.
Mm.
When my time
True.
comes,
Mm.
that's the time when I hope to see my grandchildren,
Mm.
maybe receive one final goodbye kiss on the cheek from them.
Yes.
And can you imagine which hospital will allow children to come in to see dying people and give that precious kiss?
No.
And when my time comes, that may be the time I want to say once more to my wife,
Mm.
thank you for being with me for this half a century and more. I'm sorry for every time I hurt you.
Mm.
Those few words are important, not only for me to have the relief from saying that, but also to those who left behind. They need some precious memories. And
Mm.
what do we offer them? When did this happen? This happened only in the last 25 years.
Mm.
We call it intensive careopathy. What was intensive care for? Till the turn of the century, this was where people could be monitored. Interventions happened immediately and people could be brought back to life. But
Mm.
then came the change, and somehow it is taken for granted that dying people have to die in ICU.
Mm.
And the horrors. The Supreme Court verdict of 2023 said this was wrong. Laid down
Mm.
procedure for withdrawing of artificial life support when futile. All that is happening, but the medical system is not changing. So what change? There are many policy changes that have happened. You said policy, medical education, public awareness, community action. Except in public awareness and community action, policy and legislation are happening already. 2012, India created a national program for palliative care.
Mm.
2014, India changed its Narcotic Drugs and Psychotropic Substances Amendment Act. From 2017, 2017, National Health Policy includes palliative care. 2019, palliative care came into MBBS curriculum. 2022, palliative care came into nursing curriculum. What I'm saying is the legal and policy changes have happened. The problem is that in like most other low and middle income countries, policy is not translated to action. The
Mm.
implementation gap is a mile long.
Mm.
So maybe the policies can be refined, but the more
Mm.
important step is to ensure the implementation of the legislation and policies that have happened in recent years. And you asked the question, Dr. Sarita, about public awareness and
Mm.
community action. We have to recognize that we are doing an important part of healthcare, but we are doing only part of the healthcare. Mostly it is done by the family
Yes.
in terms of time.
Mm.
And action by the community means the door. The healthcare door is locked by the healthcare professionals and the key is with us. We have to welcome them. I invite everyone listening to come and visit us in Kerala and
Mm.
see the wonderful
This call is getting diverted. Support team, can you just temporarily restore? I mean, oh, he's joined back. Okay.
I'm so sorry. This is so embarrassing, and I'm sorry that
So the network issue.
that has happened. You were asking about. I mean, I was talking about the community, and I was inviting everyone who listens to
Yes, sir.
see what kind of work community volunteers do, and this is happening in Delhi with CAN support, which works all over Delhi.
Right.
With CAN Kids,
Yes, sir.
which works all over Delhi with childhood and all over the country. They volunteers do so much. People who want to make some sense of their lives, who want to contribute, give back to the society, they do wonders. And so community action is also important. But how can ordinary individuals contribute to making no one suffers in silence? So when people ask that, we invite them to join our volunteers training program. We do many in person and online also. Now, if I am expecting a citizen who is not a healthcare provider to help out with healthcare, some basic knowledge will be necessary. So what we now do is we have 3 days of classroom, 2 days of classroom sessions. Then they go to the field in small groups, work with our team, and then they, after everybody has completed that, they come back for a final day of training. So
Right.
one of the major things to learn is communication skills.
Yes.
You and I have not had that privilege. We were not taught, like, how do you communicate a bad news? We did it instinctively, and different people do it indifferently. There is some science to it also. So that's now in the MBBS and nursing curriculum. So things like communication, things like basics of care, like the volunteers should not be agents of contagion. They will have to be careful that nobody gets, they'll have to learn hand washing, for example. So those essential training is given, and then they're welcome to assist with patient care. And they do wonders.
Right.
For example, they find that children drop out of school when there's a serious illness in the family. Our volunteers lead a program which takes care of education about 320 school and college children.
Right.
Once the support is started, it's continued till the education is over. The volunteers run a bereavement support group so that people who have lost a loved one and some get pathological grief, they need help. That kind of help is made available. So today, Dr. Sarda, you quoted the figures earlier that today less than 4% of the needy have access to pain relief in our country. The whole gamut of palliative care would be even smaller percentage. I think, as I said, with all the policy changes that have happened, we are on the steep part of the growth curve.
Hello? Hello, sir. Can you hear us? So, Puti, can you pause the streaming for some time till he joins? And the recording, maybe.
Thank you for your patience, everybody. I'm so
Thank you.
sorry about this. I'm using a different
Yeah, that's
connection.
okay, sir.
Let me try. So I was saying that in the next 10 years, now that all the policy changes are there, if by united effort we can go up to 50% in 10 years, imagine the huge mountain of suffering being reduced to half, and maybe to 90% in the next 20 years.
So, what is your message to the gynecologists who are listening to this?
That as healthcare providers, we have a duty to mitigate suffering, to prevent and treat suffering. And we have a duty to mitigate suffering, and hence not mitigating that suffering is dereliction of duty. The new MBBS curriculum has it. Most of us did not have access to it. I think basics of palliative care have to be learned by everybody, as happens in all Western European countries. Whether it's UK or Denmark or Germany, every doctor would learn to treat pain, including the use of medicines like morphine. They would all know the fundamentals of psychosocial support. In the UK, from place to place, the average medical student spends 36 to 100 hours on learning communication skills alone.
Yes.
And that's
True.
now new in the curriculum. We have not learned it. And that's a learning that we have to acquire. Our acceptance of the duty to mitigate suffering is step one. And I hope this happens.
Yes. So, thank you so much, Dr. Rajagopal, for sharing your journey, your wisdom, and your vision with us today. It's been an enlightening conversation, one that reminds us that healthcare is not just about disease and cure, but it's about dignity, compassion, and humanity. Thank you for bringing that out again so clearly to all of us, that giving us that clear message. I hope this discussion inspires our listeners to reflect on how we treat pain, suffering, aging, and death, and maybe to become part of the change by supporting palliative care initiatives, raising awareness, or simply talking more openly about what it means to care. So, for those interested in learning more or supporting this movement, you can check out the Pallium India's website and also the palliative care centers across the country. But more than that, talk to your loved ones, ask what they would want when they were unwell, and don't shy away from conversations about comfort, dignity, and quality of life. So, Dr. Rajagopal, thank you once again, and thank you all our listeners for tuning in. Until next time, stay compassionate and stay humane. Thank you so much, sir.
Thank you for the beautiful message. And thank you for this opportunity. Good
Thank you,
night,
sir.
everyone.
It was wonderful having you and listening to you. It's been so inspiring.
Thank you, Dr. Sarada.
Thank you, sir.
Thank you very
Thank you.
much.
Thank you, sir.
Good night.
We hope to meet you personally sometime.
I hope. Warm welcome.
Yes.
Kerala is
Yes.
beautiful. You can compare a
Yes.
holiday with a visit to us.
Yes, sir. Thank you, sir.
Thank you. Bye.